What we're going to talk about today is treating the pain and not the number. So you're probably wondering, what is this guy talking about? What is this number? And it's not a number related to pain, so it's not a visual analog scale or an NRS. It's the number we're talking about is about what's on the thermometer. So, right. So just as a declaration, this is an industry-sponsored event. I am receiving an honorarium for delivering this presentation. However, this presentation has been prepared independently with no third-party influence. So what I'm going to try and cover with you in the next 45 minutes is to briefly show you why fever causes so much of anxiety in patients, in children, and in their parents. Then second, we're going to review the physiology of fever. So I'm a big fan of physiology because if we have a basic understanding of physiology, and in this case, the physiology of fever, then we can understand how do we need to correct that abnormal, that pathophysiology, and get the child back to where they need to be. And thirdly, we're going to focus on the real driver of distress in most febrile illnesses, and that's the inflammation and the pain. And fourth, we're going to look at the evidence behind the analgesics that we commonly use in children. So again, like being a big fan of physiology, I'm a big fan of data, because as scientists or as clinicians, we are clinician scientists, and therefore we have to practice evidence-based medicine, and the only way we can do that is if we know what the data is and we can interpret that data. And finally, I'm going to hopefully leave you with some simple practical, a simple practical framework that you can actually use in primary care. So in your rooms, in the pharmacy, to try and manage kids with pain and with febrile illnesses. So Megan said I could ask earlier about who's in the audience here. So how many people here are from pharmacies? Pharmacists? Okay, and how many of our colleagues are GPs? Okay, and any allied health colleagues? Okay, good. So we got a nice mix. Hopefully when we get to the Q&A, we will have the opinions of everyone, because this is one of the beauties or the things I love about pain, is that this is not something that we can do on our own, in our own little silos of being the doctor or being the nurse or being the bio or being the physio. We have to work as a team. And it's the one part of medicine where if we don't work as a team, we're not going to actually fix the full problem and give that patient a better quality of life. Okay. So, fever is probably one of the most common reasons that kids are going to present to primary care. And yet the number on the thermometer is often not actually what matters to the child. What distresses the child and the parents then is the pain and the discomfort that their child feels. So today, what I want to try and do is to reframe how we approach these consultations. And instead of asking the mom or the nurse in your rooms, how high is that fever? Let's reframe and ask, how uncomfortable is this child? And then try and figure, why is this kitty so uncomfortable and how can we improve it? So, let me start with a question. When a child with fever comes into your practice or comes into your pharmacy, rushed in by the mom, what are you actually treating? So I wasn't going to actually engage and ask people that, but I'm going to. Right? So who wants to give it a shot and say, what are we actually treating when that kitty comes in? A distressed parent. That's actually very true. So this lady sitting behind you goes, yes. Okay? Because that's often the case. And it's not to say that we don't want to treat the child, but often the anxiety is from that parent, right? But at the same time, it's very difficult when you see this really sick child lying there. 3- and 4-year-olds are not supposed to do that. They're supposed to be up and boisterous. And when they're lying there looking so miserable, that's not great. So most parents will think that the number on the thermometer is what the problem is. They're going to come and say, oh, doctor, it's 40.2. And yes, that's a problem, but we're not worried about the number on its own. Getting the number down necessarily is not going to manage your patient. Treating the discomfort and the pain in that patient is what's going to actually make your treatment work better. So we need to look closely at the child in front of you. Are they crying? Are they lying there quiet and listless? Are they not sleeping? Are they refusing to drink? So not eating, not drinking. Are they maybe holding their ear, holding the throat? And then obviously mom's going to tell you, I brought Jimmy or Kalen in because the temperature is this high. And so we are going to know what's on that thermometer. But the problem is not about the thermometer. The problem is about the inflammation and what's causing the inflammation and what that inflammation is leading to. One of the things it leads to, it's the sign that we see. You'll remember from back when we were in university, they taught us about the difference between symptoms and signs. This is one of the signs that we're going to see is from the inflammation, is that temperature going up. But what that inflammation is also doing, it's giving this child pain and discomfort. So we must remember that fever is a physiological process. It's a physiological process to an inflammatory process. Inflammation can be caused by a number of things, but the commonest things that we're going to see in kiddies is due to an infection. But the pain and the infection is what makes the child miserable, not necessarily the temperature being so high. So today, instead of thinking in the norm that we normally think, I want us to explore a simple but important shift in our thinking. So instead of treating the number, I want to say, should we treat the child's pain and distress instead? So fever presentations dominate pediatric consultations worldwide. Much of the anxiety is driven by what a researcher named Schmidt in this field called fever phobia. And that fever phobia is essentially the belief that fever itself is dangerous. Now, I don't want you to walk away and say, oh, I heard that guy from Stellenbosch University say that fever is not a problem. That's not what I'm saying, right? Because fever is a sign pointing to what is the problem. And if we know that we're dealing with these hyperpyrexial, these pyrexial kids, that is a problem. But what are we doing to get the problem sorted? So like I said earlier, fever is a physiological process to inflammation, and inflammation in kids is very often due to infection. So what's actually causing the suffering is actually the pain. The sore throats, the ear pain, the myalgia, the headaches. Now, our therapeutic focus should therefore be the relief of this discomfort rather than just chasing a normal temperature. And that means we need to address the inflammation that's coming, or that is there. Okay, so this is a consultation that every GP is going to recognize, and probably a lot of the pharmacists here as well. So this is a 3-year-old arrives in the rooms with a fever. The mother's worried because the thermometer reads nearly 40 degrees. So you take a careful look at the child. Child's holding their throat, not speaking, crying. Granted, this child's not crying in the picture, but I couldn't find a picture with a crying child holding their throat. Mom tells you that she's not slept. She's refusing to eat or drink because, well, we've all been there, right? We've had sore throats. We don't feel like eating and drinking. But as adults, we know that if we don't drink, things are going to become problematic. As a child, you just know, I'm not feeling so good. Just leave me alone. I want to lie on the couch and just be miserable. So she's not drinking. So what is the problem? Is it that she's got a really high temperature and we need to bring it down? Or is the problem there an underlying issue? So if we think that that temperature is the sign, you need to figure out and be that medical detective of what is the problem. Now, I'm going to show you in a little bit why we know that what's causing the temperature going up is the inflammation. And then we need to manage that inflammation. And then we can go a little bit further and we can try and treat the cause of that inflammation. So in this girl, she's holding her throat. Very likely she's got an upper respiratory tract infection. Maybe for now it's actually a really sore throat. And if not managed soon, it's going to become a really sore ear, because we know that that's going to track up through the eustachian tube into the middle ear. But the parent, and often the healthcare worker, we focus on the temperature. Oh, Janie needs that temperature to come down. Mommy's going to feel so much better when at the next temperature, we're going to see it being lowered. And that disconnects the symptom from the number that's driving what many of our prescribing decisions. So our decisions need to be based on what is causing the fever is an inflammatory process. What's causing that inflammatory process is what we have to figure out, and that's what we're going to treat. But part of the treatment management is that inflammatory process and damping it down. And I get very excited talking about damping down the inflammatory process, because hopefully it'll all start coming back to you from your physiology days. And if not, hopefully you're going to have a better understanding so that you think, that's why I'm using this stuff. Okay. So more than 40 years ago, the guy that I spoke about earlier, Barton Schmidt, had described what he called fever phobia. So parents commonly believe that fever itself is dangerous. Now we know that fever can lead to seizures, and though if not managed properly, that can lead to brain damage. And we know that many parents will believe that the temperature reflects how severe the infection is. And the truth is, the temperature does not tell you anything about how serious the infection is. The temperature tells you about how widespread the inflammatory process is. And so there are some people who just have really hyperactive immune systems and will have really profuse inflammatory processes for the mildest infection. And we see those patients in the ICU all the time. And unfortunately, those patients often demise in the adult ICU, because it's what kills them is the inflammatory process. But it doesn't necessarily mean that they've got a really bad infection. Similarly, you can have a really bad infection and you just may be not someone that's mounting such a big response. So the fever itself is not going to tell you how bad the infection is. So what we must also remember is that that we need to see a fever, because we want to know that the immune system is actually mounting a response to whatever is causing this issue. And then importantly is to remember that in kids, the most common cause of febrile illnesses in children is actually self-limiting viral infections. So yes, we get bacterial infections in kids. I'm not saying we don't, but most often it's viral. And the challenge that we're facing now is, especially in the private sector, parents come, they've got a fever, and then you say, I'm not using an antibiotic because that's responsible antibiotic stewardship. And they're thinking, who is this quack? I am not going to this doctor again. Or they go to the pharmacist and then they think, I should have never come to the pharmacy. I should have just gone to the doctor in the first place. The reality is we need to educate our parents about these viral infections, because if we don't, we're going to, the private sector it's a business sector, and you need them to trust you to be able to come back to you. And the only way we're going to do that is either give them what they want, but then what we're doing is our grandchildren and great-grandchildren are not going to have antibiotics to treat their upper respiratory tract bacterial infections in 50 years. And so if we educate parents now about viral infections and about how to treat inflammation, that'll go a long way. Okay, so, right. Now let's talk a little bit about fever physiology. So, Megan, now's the part where you're going to lock the access so that people will only leave when you pass the test about this. Most of the test will be about this. Okay, so, right. So fever occurs when we get these cytokines called interleukin-1 and interleukin-6. And what they do, and I'm not going to go through the details of where they're produced, but essentially, if you have, can you see that? Probably not, right? Okay, so if you've got, this is the Kupffer cells, and these are essentially white blood cells. And you can see here, lipopolysaccharides is usually a bacterial infection or maybe even a virus. And then these then catch the virus, and they're going to lead to the production of interleukin-1 and interleukin-6. But wherever they are, I'm not going to talk about the liver, they're going to go up here, and they're going to start stimulating part of the brain called the hypothalamus. And so who remembers what the hypothalamus does? It does lots of things, but there we go. What do you think the hypothalamus does? And I can always learn. I didn't know it does anything in the psychology background, so tell me. Okay, so did we hear that? We've said from a psychology background, it has a lot to do with fear and memories. I've learned something new today. Thank you. Anything else? Yeah? Yeah, exactly. You said temperature regulation, right? Yeah. So the hypothalamus is the area of the brain that manages temperature regulation and also fear and anxiety. Right. Okay, so what these interleukins then do, or these cytokines do, is that normally your hypothalamus, in all of us, it's setting our temperature set point at about 37.5 degrees. So our metabolic processes are working such that our temperature in our body will be 37.5. If it goes above 37.5, like I was just talking to someone earlier and saying about 2 or 3 weeks ago, we had this heat wave in Cape Town and it was like 42 degrees on the one day. So if you were there and your temperature was rising, your body will have these physiological adjustments to cool you down. So what will it do? It will start vasodilating you. So you know on a hot day, you will find that the veins on your hands will all stick up. You will sweat profusely because sweating actually, we're producing fluid, which then we wait for evaporation to occur. And as the evaporation occurs, it drops the temperature on the surface. And so your body has these mechanisms to drop your temperature. Sometimes if it doesn't work, then you have a heat stroke. But most times it'll work because one of the most important things is actually the cortex of the brain. That'll help us temperature regulate. So we know if you're feeling really hot, you don't come in a suit. You actually come in shorts and flip-flops. And if you're actually in the snow, you don't go in shorts and flip-flops. You're wearing jackets, right? So our cortical functions. Now, if these cytokines, which are produced here because your white blood cells are attacking the foreign substance, as part of the killing mechanism, they are produced and they're going and they're resetting the temperature set point. It sets the temperature set point, let's say at 39 degrees. So instead of your body now vasodilating and sweating, you actually will vasoconstrict and you're going to try and start conserving heat so that you will raise the temperature to 39. And then as the parent now you say, oh, my baby, you're not feeling well. Let me take your temperature. And it's like, it's 39.5. But there's a reason for that, okay? So it's important that now we know, our signal is, we know there's an inflammatory process going on. We have to figure out what that inflammatory process is. Is it in the throat? Is it in the neck? Is it in the ear? Maybe they've got a UTI. Maybe they've got an appendix that's inflamed, right? That's a part of the medical detective that you're working at. But now you know why your temperature set point has gone up. So we don't necessarily want to fight to bring it down, but we want to make sure that we're going to try and dampen down the inflammatory process because ultimately we do want to bring it down because we don't want to get to a point where your temperature is so high that you're denaturing enzymes. And if you denature enzymes, your metabolic processes can't function. This is one of the reasons of why when we have really septic patients in ICU, our inotropes don't work very well because the metabolic processes that require those enzymes to work are not functioning. So we need to bring it down to get the metabolic processes in place. So I need a show of hands. Have I explained the physiology properly? Because sometimes I wonder, maybe I just get so excited that I'm not explaining it for people to understand. Does anyone, who understands it now? It's always better, there we go. I'm seeing 2 hands there, that means you really understand it. Oh, that means not everyone understands, so are we gonna have to go through this again? Okay, who understands? Okay, good. Good. So now we know why we have fever, right? So now you're thinking, right, so when I need to treat this kitty, I'm not just treating the fever, I'm looking for why they have the fever, which is the inflammation. Right. So what actually makes children miserable? In most febrile illnesses, those symptoms that distress children is the pain and the inflammation. So it can be ear pain from an otitis media, they can have a pharyngitis, they can have a viral myalgia, a headache. So there's lots of stuff. And if you have tools like this in your practice, this will help, because remember, you got a miserable kitty, they're not going to tell you. It's easier to say, oh, Janie, where is it hurting? And, Janie can point. Or maybe you can have her mom brings the teddy bear or the doll, and they can say, her doll Annie it's sore here. So things like that can get you to find out from the kid what's wrong. But again, I'm not going through that because that's like Pediatrics 101, and I'm definitely not a pediatrician. And I'm sure there's lots of other tricks that you could teach me from general practice about how you're dealing with kids, because we need them to trust us even after you give them an injection. Okay. So when pain is not treated adequately, several things will happen. Children will refuse to drink, right, because they're miserable. They become sleep deprived because they're crying, they're just unhappy. The parents become anxious. As we heard earlier, it's the parents that we are often treating. The families often return to the doctor repeatedly. So on one hand, you're thinking, yeah, that's repeat business. On the other hand, the family is thinking, oh, I've got to go back again because the doctor doesn't know what they're doing. Or I've got to go to this pharmacist because they keep giving me this stuff and it's not working. But if we use the opportunity to also educate them, then they're going to understand why you're doing what you're doing. And it's going to, it's not a magic serum. It's not going to be all better in the next 2 hours. So good analgesia is therefore not simply about comfort. It actually improves functional recovery and healthcare utilization in patients. Okay, so the key principle from modern pediatric guidance is simple. Antipyretics should not be used solely to reduce temperature, and they should actually be used, they should be used when the child is distressed and uncomfortable. So down here, I'm sure everyone knows what the NICE guidelines are. So it's the National Institute for Healthcare Excellence in the UK. NICE produces guidelines about everything. They've got some really nice, their guidelines range from primary care up to really highly faluted specialty care. And so you can always go, if you can't find local guidelines, you can always go onto the NICE website and you'll be able to find guidelines that can assist you. But I pulled these. These are their guidelines on fever in under 5s and the assessment and the initial treatment. And their guidelines specifically say that antipyretics should not solely be used to reduce temperature, but rather to manage the discomfort and the distressed or uncomfortable child. So in most countries, there are 2 medications that will dominate pediatric analgesia. That's ibuprofen and paracetamol. So we know that both, if you look here, we know that both these drugs have both antipyretic and analgesic properties. So the question is not about which drug lowers the temperature better. But it's about which provides effective relief of pain and distress to the patient that is in front of you. So we've got to move away from recipe thinking and rather use medications both at a GP level and in the pharmacy on what do I need to manage in this child. Okay, so now don't get freaked out about this. I'm going to walk you through this. So this was a big study that was done that was published in JAMA, an open network, and it was a comparison of paracetamol with ibuprofen for the treatment of fever or pain in children younger than 2 years, and it was a systematic review. Now, I chose to show the systematic review because systematic reviews is the highest level of evidence we can produce. And this systematic review analyzed more than 240,000 children. And what the results showed us is that they compared paracetamol and ibuprofen. And it was associated, in that comparison, ibuprofen was associated with a slightly greater reduction in pain, with faster fever reduction in the early hours, and similar rates of adverse events. Now, let me show you how, I'm going to try and go very quickly on how you actually read these forest plots. Because once you understand how they work, when you see them, you're going to think, now I know, and this makes understanding it so much better. So each horizontal line here, and you can see where the pink arrows come up, those lines, those represent a study that is comparing the two, the ibuprofen and the paracetamol. Now the square in the middle of it, and I'm not sure if you can see it properly, but there's a square in on each of those lines. The square in the middle is the result of that study. So the size of the square will tell you how much weight that study carries in the systematic analysis. And the length of the horizontal line, it shows you the uncertainty of the results. So in other words, the longer the line, it means the more uncertain we are about whether that result is actually a result or whether it is by chance. Because in research, that's always what we're trying to figure out is what we found, is it the actual result or is it by chance? And that's why we do things like sample size calculations and power analyses. Okay, now the key part is the vertical line in the middle. So this is the line of no difference. So if a study crosses that line, it means that there's no clear difference between the two products, or the ibuprofen and the paracetamol in the case of this one. If it sits to one side, it means it favors the drug over the other, right? So, example, if this is your the vertical line, and we've got a study which sits on this side, that means where the whole horizontal line is on the one side. So, for example, this one here, the whole horizontal line is on the one side, if I can see correctly, yeah? That means that study's favoring this side. If there was one with the whole horizontal line on this side, it meant that the study favors this side. And if it's crossing, like here, it means we're uncertain if there's a difference between the two. Then, at the bottom, you see this diamond, right? So the diamond is the cumulative result of all the different studies, right? It's the meta-analysis of those different studies. And the diamond represents that overall pooled result from all the studies. And what you can see here is that most of the studies here are clustering around the line of no difference, right? But the pooled estimate, depending on which one you're looking at, because they're looking at different things here, are either sitting very close to it, or like this one is sitting clearly on the one side. Okay. So, the important message here is not that one drug is dramatically superior. The message here is that ibuprofen, I should have told you that this side is on the line, this is the paracetamol side, and that's the ibuprofen side, and it's the same here. Paracetamol, ibuprofen on either side of the vertical line. So if you look at where the diamonds are, right, what this is, many of the diamonds are either crossing over the line of uncertainty or they're touching the line of uncertainty, but some of the diamonds are favoring the ibuprofen side. So what the message we get out of here is that ibuprofen is a highly effective analgesic option in febrile illnesses associated with inflammatory pain. So the evidence from this 2020 systematic review suggests that ibuprofen may provide better short-term pain relief than paracetamol in some pediatric settings, but the estimate is actually based on very limited trial data, and it should not be presented as a definite randomized control trial finding, but rather a strong signaling that this is the case, right? Was there another one that I needed to? Oh yeah, there was. Okay, so that's the diamonds that I actually meant to show you earlier. You can see now the green arrows are showing us where the diamonds are, and you can see some of them are crossing over the line of uncertainty, but some, like that one in the bottom there with the arrow, is clearly showing a benefit towards the ibuprofen side. Okay. Right. So in young children with fever managed at home, in this paper, this was something called a pitch study, and this was an RCT, and I just wanted to show you what the pitch study had come up with. So in young children with fever managed at home, ibuprofen was actually more effective than paracetamol, and combined, it was more effective than paracetamol, and combined paracetamol and ibuprofen together was more effective than either of the drugs alone, reducing the time with fever over 24 hours. But there's a caveat here, right? Is that the pitch study was about fever. It was primarily about fever reduction or time without fever and not about pain relief. So you're probably thinking, then why are you showing us this when you just spent the last 20 minutes telling us it's not about the number, it's about the child? It is, right? But remember that if we use a product where we lower the fever, what are we doing? Is we're reducing the interleukin 1 and interleukin 6, which means less of those are going to the hypothalamus, and the set point change is now different. How does that work? And that works because I need to tell you then how does ibuprofen work well for inflammatory pain. So, essentially, in all of our cell walls are made up of something called arachidonic acid. If you have damage to your cell, that can be from trauma, it can be from surgery, it can be from a viral infection, right? That cell is going to break down, and the wall now is broken down, and the arachidonic acid gets released. Then we have this thing called phospholipase A2, which comes and works on that arachidonic acid, and it releases what's called free arachidonic acid. So now we've got all this free arachidonic acid flying around, but remember, our body is this metabolic machine, so it needs to metabolize this. There are 7 pathways that arachidonic acid can get metabolized down, but there are 2 that are really important, and I'm only going to talk about the one today, and I'm going to talk about the cyclooxygenase pathway. It's ringing a bell here. You're thinking cyclooxygenase, oh, COX. Oh yes, people tell me about COX drugs. Right. So what the arachidonic acid comes here, and it gets metabolized by the COX enzymes, either COX-1 or COX-2, and that leads to the production of the prostaglandins and the leukotrienes. So those prostaglandins or the cytokines is that interleukin 1 and 6 that I spoke about. So now, that's the pathway. That's why, remember, we're getting inflammation because of damage to the cell. Arachidonic acid is getting produced. It's now going down a metabolic pathway leading to the production of this cytokines and prostaglandins that's going to go to the hypothalamus and adjust the set point. It's also going to cause a lot of inflammation and pain. Now, if we use something that's going to block these COX enzymes, this arachidonic acid is going to come here, and there's nothing that's going to be able to convert it from the arachidonic acid to a prostaglandin, which means now we don't have interleukin 1 and 6, and we don't have these leukotrienes available, which means nothing can go and adjust the set point. But importantly, more importantly, nothing can actually cause inflammation, which is going to lead to the discomfort and the unhappiness in the child. And that's why these non-steroidal anti-inflammatory drugs work so well for inflammatory pain, because it is blocking off these receptors that are primarily responsible for producing the pain, inflammation, and the fever. So, lowering the number on the thermometer does not necessarily reduce the child's well-being. The comfort and the function are much better clinical endpoints. If you are a practitioner and you follow up with mom or dad, they're gonna come to your rooms or come to the pharmacy or phone the receptionist and say, no, Jimmy's doing so well, he's actually running in the garden again. I know that when he's running in the garden and playing, he's feeling better. That's because his inflammatory processes are now dampened down. Okay, so I've got a few minutes. I have to go a little bit faster because otherwise we're not going to have Q&A time. Right. So I want to talk about some myths and the myth of alternating drugs. So there is this idea that we must alternate paracetamol and ibuprofen, and it's become common practice. But systematic reviews have actually suggested that additional clinical benefits are actually minimal, but what increases is dosing errors. So ideally, you want to actually try and stick with what's simple for mom in terms of dosing instructions. We know from the previous paper, that systematic review or the pitch study, is that ibuprofen works better than paracetamol alone, and it works, but ibuprofen and paracetamol together work well. Now there's a trade-off here. Do we give the combination of the ibuprofen and the paracetamol and risk a dosing error, or do we try just the single drug like ibuprofen on its own and see what happens? In the majority of cases, your kid is going to get better with that. If you don't, then you know that you can then say, okay, mom, I'm going to add on this now, because we know on that graph that there's a certain group that will actually improve as well. But again, remember, pitch was about fever and not about inflammation, but we're using it as a surrogate marker. Okay, so that means you must know about dosing principles, right? So for ibuprofen, your dose is going to be in the range of about 5 to 10 milligrams per kilogram. And in kids, you must always use per kilogram dosing. We never use anything that is not per kilogram, because you get, you can get a 10 kilogram 5-year-old and you can get a 40 kilogram 5-year-old. The dosing is very different for those kiddies. You can see the dosing information ranges there from 3 to 6 months right up to 9 to 12 years. And after that, they actually become heavy enough where you can actually use adult dosing. Okay, what about safety considerations? So things to remember is that hydration status is particularly important when prescribing non-steroidals in children. So remember I said, these sick kids, they don't like drinking. You must make sure that mommy is going to make sure that they drink. And one of the things that I remember from my pediatric rotation many moons ago as a student is that thirsty children will drink fast and then they will vomit. So you don't let the kiddie drink fast. Mom's got to give them no more than 5 to maybe 10 mils at a time. Wait a little bit, then a little bit more and a little bit more. We want to get them rehydrated. We want to see those sunken eyes come out. We want to see capillary refill time improve. And so we make sure we must rehydrate them, and because we want to avoid non-steroidals in dehydration, we want to avoid it when there's a child who has renal impairment. So if mom tells you, my child has nephrotic syndrome, you're not going to give them ibuprofen, then you go with paracetamol. If mom tells you, my baby's got a non-steroidal allergy, or if they've got an active gastrointestinal disease, those are the ones you're not going to use. But otherwise, everyone else is pretty much the ones that you want to use this in. So there's lots of papers about this, that ibuprofen is as safe as paracetamol for short-term use in children. And one of the common concerns about ibuprofen in children is whether it's less safe. So the best comparative evidence does not support a concern in routine short-term use. And this 2009 systematic review and meta-analysis by Southey and colleagues actually found that ibuprofen and paracetamol had comparable safety and tolerability in children treated for pain or fever, and that included similar rates of gastrointestinal, asthma-related, and renal adverse events. Now, more recently, Tan and colleagues in their 2020 systematic review, and this is the one I showed you the detailed forest plots for earlier, they also did a systematic review and meta-analysis of children younger than 2, and they found equivalent short-term safety, while ibuprofen was slightly better for pain relief and fever reduction in the first 24 hours. So the key message here from the data is that when used appropriately for the right child at the right dose, ibuprofen is as safe as paracetamol for short-term pediatric use. But you want to remember that ibuprofen is not recommended for infants younger than 6 months without a clinical assessment. As a doctor, you can actually decide what you want to use, but make sure that you do a full assessment and that you document why you're using it. And please always use weight-based dosing. You can either have a little calculator next to your prescription pad, or some of the pharmaceutical companies make these wheels. That'll be very helpful. Just make sure you always weigh little Jimmy or Janie, right? And then I think the really important part of this, if anything we're going to take home from this, it's about this. It's you got to counsel the parent, right? Because if you don't counsel the parent, they're going to think you don't know what you're doing. So take the time to explain to mommy that fever is normal. We want to see a fever because we want to know baby is mounting a response. Doesn't mean we want to keep it there. We're going to get it down. But we're going to do it by treating the discomfort. And then we want to maintain hydration. If mom says, no, he doesn't like drinking, I'm just leaving him, his throat is sore, you've got to go, no, mom, you've got to make sure he's going to drink. And don't give him something that's going to make, with high sugar content, that's going to make him pee. You want to give him something with high electrolyte content that's going to make all that fluid get reabsorbed and intracellularly. And the last thing is, we need to watch for warning signs. Is the baby getting worse? Are they becoming listless? Are they not improving as you would expect them to? Bring them back to me if they are not. Okay, so some practical advice for you in the rooms is there's 3 questions you're going to be asking, right? Is the child distressed? And then you need to ask, is the analgesia that I'm giving appropriate? And lastly, what's the safety net advice that is needed to provide to that parent? Okay, so in conclusion, I'm going to say, let me leave you with one simple idea, that children don't suffer from numbers. They suffer from pain. The thermometer is only measuring a physiological response to the inflammation. Right? What matters to the child and to the parents is whether the child can sleep, can drink, can play, can feel comfortable. When we relieve pain, we improve function, we reduce parental anxiety, and often avoid unnecessary repeat consultations. So the next time the parent asks, doctor, how do we bring the fever down? Remember that the real question is not about the temperature. The real question is, how do I make my child more comfortable? So, treat the pain and not the numbers. And I'm going to leave you with this last thing. If you're interested in pain, the Pain SA conference is May. It's just up the road at the Indaba Hotel. It's a great place to meet other people who are interested in managing pain, to learn more, and to get CPD points. Thank you.
Thank you, Sean. A different perspective on pain, particularly in kids, is useful. Let's do questions, and then I'm going to shoot with some of my own. Anyone with a question? I'm doing the running.
Hello, sorry, I'm Dr. Groevier from Kimberley, the state hospital there. I work in the ED, and this is actually brilliant what you're trying to say. And the first thing in all patients, not just pediatrics, is pain management, because that is already an indication that you're helping, especially in a busy ED where you can't get to a patient really quickly. Obviously, in kids, we try to prioritize. Just one sad thing, or more out of personal experience. Proven, Panari, yes, it works, but if you can add a little bit of Valoron, obviously it's not here in South Africa anymore. A quiet child makes a happy doctor.
Any comment on that?
So I think what you're alluding to is the anxiety. You want to address the anxiety. So Valeron, which is not in I don't think it's in production globally anymore, addresses the anxiety. There are other ways to address that anxiety. And now that we don't have that product, the things that you can do is, give them a toy, distraction. Be the clown, be the friend, reduce the inflammation. But you want to address the anxiety, exactly. That's true. There are lots of people that are terrified of clowns.
Thank you, Prof, for the presentation. My name is Dr. Boni Singu. I'm from the University of Namibia School of Pharmacy. You were talking about the dosing of ibuprofen or paracetamol in children, that it's preferred to give per kg. Some say BSA is a better way to dose children than per kg. Why are we not talking about BSA, or is it maybe too inconvenient to use?
You mean body surface area? Yes. So, as a pharmacist, you probably are more knowledgeable than me about dosing. But body surface area is impractical in a clinical setting. I don't even know how I would do that. I mean, we'd have to do the height of the patient, and so weight is probably the next best thing that we have. We have to be pragmatic. So, it's one thing to say to everyone, this is the right thing to do. But when you're sitting like the doctor that was there earlier, and you've got 200 patients waiting, you have to be moving, so you have to be pragmatic. What is going to work in that situation? If you're a general practitioner and you've got, 15 people waiting in your waiting room without appointments, and you've still got full appointments, you need to move, because the longer they wait there, the more unhappy they're going to be. You need to be safe, but you need to be pragmatic as well.
That's correct, and I agree with you. The physician is usually very busy seeing the patients, but there's a very easy way of calculating body surface area. There are several formulas you can use. And, it's the physician does the diagnosis, then maybe it's the dose, then the pharmacist should check that up and do the correct calculation of the dose. I think that's how we should do it.
I agree with you. I think that when I talk to pharmacists, I often say that you have to be the guardian, because I will make a mistake. I mean, any doctor who doesn't make a mistake is lying that they haven't made a mistake. What I don't see happening in South Africa, or maybe it does happen and I just haven't seen it, I don't know when the pharmacist actually takes the time to pick up the phone and say, hi doctor, you've prescribed 500 milligrams for this 10 kg child. Did you not mean 50? And then hopefully the doctor goes, oh yes, thank you for picking that up, as opposed to, who do you think you are? I know what I'm doing. And that's the problem, right? And this is why I keep talking about, we can't work in silos. It's across the entire spectrum. It's great if the pharmacist is going to be able to correct the dose, but the dose still has to be calculated by the doctor. And that's why I say you've got to be pragmatic and safe.
Yeah. Thank you so much, Prof. Talking of addressing the anxiety, I feel sometimes we are treating the parent and not the child. Because, for an example, if the parent will come to you and said, my child, the last time the fever was so high, they had seizures. Like febrile seizures. And now they are so anxious, then they'll tell you, this temperature was sky high, midnight, and now when you see the child is completely relaxed, running around, and so, I think it's more about giving more counseling to the parent and explaining that, fever does do that.
You're 100% correct. Earlier, that colleague there was saying the parent. You're right. I think, I have kids, and thankfully they're older now, but when they were young and they had temperatures, I was panicking as well. And I'm someone who has the knowledge of this physiology. So can you imagine, the general public? So that's why that counseling becomes very important. And the counseling can't just be when the child is sick. They're not going to take it in when the child's sick. And this is why I'm a big advocate of the general practitioner being the gateway into healthcare. People just want to run to specialists all the time. They're increasing the cost of healthcare in the country, but our GP should be the gateway because you know mom, dad, baby, the sister, the brother, and you know the family history. And they're going to come to you over and over, and your counseling can be over a period of time. You can educate your patients. But we're not seeing that now, and we need to move back into that system.
Hi, Prof. I'd just like to find out about the COX inhibition. I think the first question that I want to ask is ibuprofen selective for COX-1 or COX-2? In which case, then, would we not have a problem with children that are asthmatics who tend to have a lot of inflammation? That if we inhibit COX, then by way of negative feedback, we can have rebound inflammation as well. Is that not a concern?
So let me ask your first question. Ibuprofen is a non-selective COX inhibitor, which means, actually I can do it. It's fine. It's a non-selective COX inhibitor, which means it blocks both COX-1 and COX-2. The selective COX inhibitors selectively block COX-2. Okay, the difference between them is primarily a gastrointestinal protective mechanism. So if you block only COX-2, you don't block the production of the prostaglandins that protect the stomach. In short-term non-steroidal use, it's not an issue. And in patients who don't have gastrointestinal issues, it's not an issue. It's a problem in long-term use and in patients who have like ulcers, right? Those are the ones you're going to use COX-2s in. But for short-term pain, inflammation, and fever, non-selective COX inhibitors are fine. Your next question is a very good one. And so COX inhibitors in general, whether it is COX-1 whether it's non-selective and selective, will give us the risk of what's called aspirin-induced asthma. It's just called aspirin-induced asthma, but it's actually asthma for exactly the reason. The reasoning that you asked about is not the reasoning that you gave, right? So what happens is, remember I said to you that the cells break down and we've got arachidonic, let me see if I can find that somewhere. I don't know where it is. Okay, well, we've got arachidonic acid. I'll go back to the one I had earlier. Right. So we got arachidonic acid that now has to get metabolized. I said there were 7 pathways. I said there were 2 that were important, but I'm only talking about 1 today. The other important pathway is called the lipooxygenase pathway. The lipooxygenase pathway, you get the arachidonic acid being metabolized by the lipooxygenase pathway to produce things, leukotrienes like bradykinin and histamine. So now, if you remember, why do we get asthma? Because we get bronchospasm of the smooth muscle in the bronchioles, on the bronchi, and that's because they are triggered by bradykinin and histamine. So the reason that we have a higher risk for asthma with non-steroidal anti-inflammatories is because we are closing down one of the 7 pathways. The arachidonic acid is still there, it didn't go away. Right? So it's now getting metabolized down 6 pathways instead of 7. So there's more that's going down the lipooxygenase pathway than would have been if there were 7 pathways, producing more bradykinin and histamine. Now, this is only a problem in brittle asthmatics, so ones that you have no control over, or patients who are actively wheezing. If you have someone who has mild asthma, they've got atopy, it's probably not an issue. But on the brittle asthmatic, I would not use a non-steroidal in general. And in someone who's actively wheezing, I would be cautious. I would have to weigh the pros and the cons of the pain, inflammation, and fever versus whether I can control that bronchospasm with a thing like salbutamol. So that's my response. I hope that answers the question. Yeah, it's not about rebound inflammation.
We have time for one more question. Is there one? All right. Thank you for taking us back to the university physiology classroom. And thank you for that stretch of the brain. I think at the end of the day, we've got to remember that the physiology runs this thing called the human body. So it's good to be reminded of it every now and then. Thank you very
Thanks
much for
very
your
much.
time. And hopefully we'll see you here next year.